The WD system builds in staff and facility protection as an integral piece to quality patient care. For us, this begins at triage. Here we are on the triage page of the WD system. For orientation, notice that at the top of the screen that we have Shinta Indrajaya. She is 26 years old, female, has no known allergies, and it's April 5th, 11:22 a.m. The nurse has recorded the reason for the visit. Shinta is having difficulty breathing since yesterday. The nurse has also recorded vital signs. Out-of-range vital signs are highlighted red, indicating that Shinta is sick. She has a fever to 38.2, her heart rate is 123, and she has a concerning O2 saturation of 90%. In the WD system, staff and facility protection at triage is not left to the opinion of the individual. Instead, WD presents the institutional standard in the form of a checklist to guide the disposition of the patient. To start, staff may want to know what informs the staff and facility protection checklist and if it is up to date. They can check by clicking on Authors. Clicking the author's reference lists the checklist authors and relevant information such as the last update. This was last updated April 5th, 2020. Also, resources can be tapped in line with care. I like the Hopkins Coronavirus Resource Map. This opens up this resource in a separate window. Having satisfied any nursing concerns, the patient assessment can begin. Notice how, depending on the history and physical presentation of the patient, the system directs the triage nurse with relevant information. For example, if the patient doesn't have COVID-19 exposure history and no symptoms or signs of upper respiratory tract infection, then they are cleared to go to the main facility. This includes even if the patient has mental status changes. Conversely, if the patient has COVID-19 exposure history or upper or lower respiratory signs and symptoms, they are directed to a safe area both for testing and care. So let's give the patient fatigue, doesn't change disposition, but fever. Here the triage nurse is directed to ask the patient to sanitize their hands, to give them a simple mask, and then escort them to the testing area. Now, let's make the patient very sick. They're having a history of difficulty breathing, they have sore throat, they have signs of respiratory distress. In this case, the nurse is directed to place a mask on the patient, to alert the respiratory team, and to call the orderly for immediate transportation. The logical framework behind each of these three dispositions, main area clear, testing in an annex, and high risk zone, is expressed explicitly by clicking on the rectangle of interest. Let's click on the high risk zone system logic. This system is saying that any respiratory distress or any mental status changes combined with respiratory signs and symptoms or high exposure risk must be directed for immediate care. Within this real-time feedback system, the clinician's documented findings are expressed by an interrupted green line. But when the totality of decision meets the system logic, the interrupted line turns solid and a smiling face appears. So in this example, it is the respiratory distress of the patient that rationalizes movement of the patient for immediate care. Note, WD can quickly adjust the logic behind any of these three patient paths or add new paths depending on the design of the healthcare facility. At the same time, the WD system offers a starting off point for facilities that may not have experience with infectious disease epidemic control.